Hello, everyone, and a very warm welcome to this internal session of the team group, where we will be the candidates will be acting as co-examiner and hot seat candidate. We have a number of volunteers with us, including Dr. Sayan, Dr. Kamal, Dr. Amara, and Dr. Sahar. And we will go along with them one by one. Dr. Sayan, thank you so much for being with us. Let me share the screen. And then, just as a practice, request remote control from me from the Zoom options, so that we practice it before we start.
So, like, if I request, then how will I control after that?
First request to me.
Yeah, can you?
Yes.
Can I please have the mouse control? Yeah.
Actually, it's Dr. Malik who has asked me from it. I want you to ask the access.
Okay.
Okay, let me do it the other way. Okay.
You mean I have to type somewhere?
Okay, leave it. It would take time. Leave it. Let's go on. Your first case, Dr. Sayan. Let me start the timer.
Yeah. Okay. So I'm provided with a left breast lump of few months duration, an 85-year-old female patient.
Yes.
I'm provided with mammography images showing bilateral breast and craniocaudal and MLR projections, where I can see multiple calcifications seen in linear projection in both the breasts in a craniocaudal view. The calcifications are arranged in the ductal pattern and appear to be linearly organized, radiating outside from the nipple towards the periphery. Going by the age of the patient and the pattern of appearance of the calcifications, I'll group these calcifications in the form of linear segmental calcifications. I'd like to correlate the findings with ultrasound if it is seen. Otherwise, if it is ultrasound correlatable, then I'll go for ultrasound guided tissue sampling for further diagnosis. Otherwise, we'll go for a stereotactic sampling, such as triple testing, a triple marker test, and also assess for any lymph nodes if they're visualized on imaging. And following that, we'll refer the case to the breast surgeon and take this up at the breast MDT.
Okay. So can you describe these calcifications a bit more for me? And can you see anything else other than the calcification in this mammogram before you proceed to ultrasound?
Yes. There is a focal ill-defined lesion, high density lesion present in the lower quadrant of the right breast, which is retroareolar in location in the middle.
Lower and I'm giving you CC and oblique. Lower and
lower and towards inner aspect.
Yes. Okay. Good.
Yeah. Lower inner aspect. It appears to be fairly high density in nature with slightly irregular lobulated margins.
Yes.
And the calcifications appear to be radiating out from the lesion. So considering the age of the patient and the appearance of the lesion, I will give it a BIRATS 4 and suggest ultrasound correlation. If it is seen ultrasound, we'll go for a tissue diagnosis if feasible, and also assess for surrounding lymph nodes if needed for sampling. And after that, we'll go for triple testing to check for the status of the tissue and suggest the discussion of the case, the breast MBT. If the lesion appears to be resectable, or if it turns out to be malignant, then according to the surgeon's wish, we'll take it from there.
Okay, so the treatment is on the surgeons, right? Okay, can you tell me the terms multifocality and multicentricity?
Yes, multifocality basically means that multiple areas of involvement within the same breast, which are linked, like related to each other. Multicentric means different pathologies arising without being related to each other.
Okay, we'll come back. Your next case, okay?
Fall with hip pain, past histories with a 50-year-old female.
Yes.
I am provided with the frontal projection pelvic X-ray of an adult patient with fall, with the history of fall. I can see the mountain appearance with extrophy of the bladder, where the pubic symphysis shows diastasis. This needs urgent orthopedic referral. I'll immediately transfer the case to the orthopedician for management of the pubic diastasis. After that, we have to assess for the presence of other complications, which probably include extrophy of the bladder, and the patient may need neurosurgical opinion.
Okay, did you use a specific term, something I missed in the beginning? I couldn't understand. Did you use a specific term?
No, I said Monterey appearance.
Yes, the Monterey appearance. Okay.
Yes.
So you are given, this is the terminology you are using for this widening of the pubic symphysis, right?
Pubic symphysis, yes.
Okay. This is a skeletally mature or an immature?
It's a skeletally mature patient.
So is this an acute problem or a chronic problem?
Going by the appearance, this looks like a chronic problem because the pubic symphysis appears to be quite widened.
Yes, because you said that we have to do an urgent referral to orthopedics.
Okay, correct.
Okay, so this is a chronic problem. Excellent. Okay, but the patient has left hip pain. Anything to explain it? As you correctly diagnosed, this is Monterey. This is chronic.
Yes, yes.
Okay?
So
you said that this is bladder extrophy, most likely, right?
Yes, yes. So as I'm looking at the left hip, I can see there is some irregularity present in the femoral head region. Excellent. With loss of height, which suggests probably there is underlying avascular necrosis going in the left hip. So for this particular area, I'll suggest an MRI of the left hip joint to look for underlying marrow edema and pathology. And at the same time, I like to assess for the cause of avascular necrosis.
Okay. Yeah. Okay. Avian, fair enough. Maybe in this case, it was simple osteoarthritis, but it's good that you found the cause in the left hip. That's good enough. Do you know of any association of bladder extrophy with any syndrome or any complex?
Yeah, bladder extrophy. Beckwith-Widman.
Okay, no issues. Next case.
Okay.
Go ahead.
Okay.
You're doing
abdominal
good.
Swelling in a male patient.
Yes.
So I'm provided with the abdominal X-ray of abdominal swelling in a male patient. I can see multiple calcified foci present within the abdomen, some of which appear to be distributed within the peritoneum. There are some well-defined rounded densities present in the left hypochondrial region. So going with this diffuse calcific pattern, I'm thinking of the possibility of peritoneal disease, which can be due to metastasis or any other systemic condition which has resulted in calcified nodes, probably in disseminated infection, like an old healed tuberculosis. So in my usual practice, I will suggest a cross-sectional imaging for better analysis and to assess the underlying visceral organs. At the same time, I take the history of the patient to see if there is any history of any weight loss or any chronic debilitation.
So you gave me two differentials here, right?
Yes.
One you gave as peritoneal disease, that there is some peritoneal nodules which are calcified. Is that so? And the second, if I remember, was infection, right?
Yes, yes.
Like TB. Okay.
Yes.
Let me say reasonable differentials for sure. But let me say that there is no calcified nodes and there is no peritoneal disease. And the patient has genetic disease. What will you think of?
Genetic disease means like it's inherited.
Yes.
Okay. So in that case,
and we are doing GU and MSK.
Yeah, that is right.
The rest will not come.
So
it's tough, I know, but
in that case, I'm thinking of the calcifications which are diffusely scattered. Trying to find out whether the renal outline is not clearly seen in this patient.
Excellent. Yes.
So I'm thinking of the possibility of renal disease.
Yes.
And since it can be like an autosomal
Yes,
dominant, or like
yes,
autosomal dominant like autosomal dominant kidney disease
excellent.
for.
Yes, this is what it is.
Okay,
It's a very severe form, like it has been long
okay,
standing, and basically the
okay,
kidneys are enlarged and the
okay,
cysts have been peripherally calcified. Excellent. Okay.
okay.
Give me the associations, a
Of
few of with
ADPKD.
polycystic kidney disease. Yeah.
Yeah, it can be associated with polycystic liver disorders, along
Yes.
with can be pancreatic cysts, splenic cysts,
Excellent.
like cyst, and
Something above the diaphragm,
it can be associated with lung,
more above the neck.
ADPKD.
It's not very common, but can happen.
Anything
No
to do
issues.
with I'm okay.
It's okay if you
Uh,
don't remember. No problem.
Ocular. Okay, okay, fine. I'm not sure about it.
No problem. No problem. You are doing very well. You are doing very well. Go ahead. Next case.
Pelvic pain, difficulty with urination and defecation.
Oh, sorry. This was supposed to be. I wrote that show X-ray number 3 first. Go ahead.
So I'm provided with a chest radiograph, frontal projection of a skeletally mature adult patient. I can see there is a widening and sclerosis of the right humerus with surrounding increased soft tissue. So the patient has pelvic pain, if I'm not wrong. So going
Yes.
with the history, this bone appearance appears to be suggestive of a bony pathology, probably a bone mets, sclerotic bone mets. And
Can you again describe the bone findings for me?
there
Forget
is a,
about the pelvic pain.
okay,
What do you
fine.
think is happening here? Yeah.
There is widening of the metadiaphyseal region of the right humerus
Yes,
with
this
rounded
one.
yeah,
Yeah.
and with surrounding increased soft tissue. And the visualized chest and other bones appear to be normal. There is I
No
cannot see
soft
any
tissue.
obvious.
Can I convince you? There is no soft tissue. Just
Okay,
this
just
broadening.
the bone, broadening of the
Yeah.
bone,
Mm-hmm.
and there is some cortical irregularity also.
Mm-hmm.
So bony enlargement.
Mm-hmm.
This suggestive of primary bone pathology.
Like.
So since it's an adult patient, I'm thinking of the possibility of Paget's is one possibility.
Uh-huh.
Though there is no coarsening of the trabeculae. Other
Yes. Mm-hmm.
other possibility can be that of a primary bone tumor
Mm-hmm.
with causing expansion of the bone. Other differentials will be for an adult patient like Mets myeloma, but
Okay. No
or
problem. Let's come to
lymphoma.
the pelvis. Let's come to
Okay.
the pelvis. What do you see here? It might
So
be simpler on this.
I can see a catheter in situ,
Mm-hmm.
and apart from that, there is some widening of the metaphyseus in the left hip joint. As I mean,
What do you mean metaphysis of
no,
the hip
sorry,
joint?
sorry. I mean,
Uh-huh.
bilateral neck of the femur appear to be slightly widened,
Excellent.
and there are some like calcific foci present within the pelvis. I
Mm-hmm.
am not sure, but there is some haziness in that region. So
Where is the
metaphyseal
haziness? Sorry.
in the pelvic,
My bad.
in the pelvis,
Okay. Okay.
uh, along with the catheter in situ. So metaphyseal widening, bilateral bones, along with the same patient having a bone disorder, it can be a metabolic disorder as well.
Okay.
Hello.
What will you like to do next?
In my usual practice, I like to screen for, take the history for an underlying pathology of the patient or any long-standing pathology.
Uh-huh. Anything else?
It can, or if there is any related kidney disorder like renal function test to
What if I tell
assess.
you it's not metabolic?
Okay, if it's not metabolic, it can be some systemic condition
Mm-hmm.
like resulting from renal disorder, but usually that results in osteodystrophy.
Can I convince you? Is this something? And is this something?
Okay, there are some osteochondromatous projections. So in that case, it can be uh, multiple osteochondromas. Diaphyseal ecclesis is a possibility.
Okay. With?
Diaphyseal ecclesis with Madelung, but not Madelung. I mean,
Okay. What will you do next? Next imaging modality.
next imaging modality will be that of the hand. to see for any any abnormality in the forearm, or
Other than the X-ray.
We can go for an MR evaluation to check for any underlying myelochange.
The clinician does not want to wait for MRI. It will take time. No slot in the department at the moment. What will you do?
Okay, then maybe like only for imaging investigations or biochemical as well?
No, radiological. What will you do?
Radiological.
Radiologically. MRI not possible. The clinician wants to know more. What imaging modality will we take? CT.
CT, okay.
Okay. Okay, I am showing you the, let me show you the arterial phase, okay? Go ahead.
So the arterial phase, there is enhancement within the bladder region, or rather in the pelvis, which appear. Is this a plane scan or this is the arterial phase? Okay.
This is arterial phase.
So I like to see the plane image once to make sure
this is I have only bone window.
Okay. Yeah. So there are multiple like hyper dense foci present in the pelvis, which appears to be enhancing. And on the sagittal image also, there appears to be a mass within the pelvis region showing multiple hyperdense foci. So this looks like a tumor with probably from the bladder, like a bladder sarcoma or abdominal sarcoma.
Okay. There is catheter, right?
Yes.
Okay. So
sorry, it's a prostate, I think. Is the
okay. Sorry.
Because I'm not able to see the bladder separately, so I initially thought it's a bladder tumor, but it can be the prostate also. Since going by the anatomical location, in that case, you have to think of metastasis with the prostatic primary.
Okay. Thank you so much, Dr. Sayan. I think you did well. It's never easy to be in the hot seat in front of so many people, and things which every other person can see. When I sit on the hot seat, I cannot see. That's the stress.
Yeah, that is true.
That is stress, and that is what we want to overcome by these practice sessions, right?
Yes.
You did. You kept on. You kept on talking. You kept on describing. You were logical. It was very good. We'll just have a quick review of your cases, and with all this review, trust me, it's only so that we all can improve ourselves, right? There is nothing of the criticism. There is nothing of that sort. So your first case, I know it was a bit unnerving because it seemed like it's some sort of case of Dr. Maheen when she showed us the DCIS, right?
Yes.
This is exactly what I thought when I saw this. But if I can convince you, you see all these calcifications are thick. They are leany. They are rod-like. Or you can use the word
plasma cell
yes,
mastitis?
This is plasma cell mastitis. The case which I got, which I incorrectly said is benign calcification, actually had haphazard calcification. It had pleomorphic and it was scattered. So that is why it was DCIS. But this one is very symmetrical, very thick, linear, rod-like. So this is plasma cell mastitis. But what was good that you did not stop after saying these calcifications. This was important, okay? And this is what is suspicious. So the words which you can use for it is like irregular, speculate, suspicious lesion, okay? You can call it M4 or M5 or BIRAT 4, BIRAT 5, everything is acceptable. One thing which we forget to add when we are in the hot seat, although we do it every time, is comparison with the previous, right?
Yes.
We will always say that there is comparison with the previous. Otherwise, everything was fine. So this is plasma cell mastitis with suspicious lesion. And you rightly said, I think what I learned from Dr. Maheen, because we don't use it in our practice, but in UK, they would like to listen to the word triple assessment.
Yeah.
Triple assessment would include this clinical physical examination. It would include additional mammographic views or ultrasound. It would include the biopsy. So we can say that now I would go for the triple assessment to do the, we will say the same thing, the words which you used, but just a few buzzwords makes the clinician, makes the examiner relaxed. Okay, he has said the right word, right? Then you rightly said that you would look at the axilla to look for the lymph nodes. And one thing which I remember from Dr. Maheen, that it's not our job to diagnose malignant lymph nodes. It's
Yeah.
our job to point out that this lymph node looks suspicious, or this cortical thickening, or this is rounded, and FNAC should be done, right?
Yeah. Yes.
So otherwise, so these were some points regarding the multifocality and multicentricity. Honestly, I also forget every time. Multifocality is the lesion in the same quadrant.
Okay.
Like this is the lower inner quadrant. In the same quadrant or within 4 centimeters of the primary lesion. Okay, this I'm telling you from rapid review of radiology, Shahid Hussain.
Okay.
And multicentricity is when it is in another quadrant, or more than 4 cm, or in the contralateral breast, as you said. Okay. So focal is in the same, near, and center is other quadrant. Okay. Otherwise, this was perfect. This bladder extrophy case, you did perfectly. The word which I wanted to listen to, and I think the examiner would also like to hear, is manta ray. And like lots of things, okay, what is manta ray? I didn't know. So this picture for you, this is manta ray fish. So this is how the bladder extrophy would look like. And you rightly said everything. Only that, this is because we are thinking, I told you this is chronic. So not urgent referral, but it's a chronic disease, and it can be managed accordingly. And this is, as they described, as osteoarthritic changes.
Osteoarthritis.
The association I was asking from you was the OEIS complex, omphalocele, extrophy, imperforate anus, spinal anomalies. But these questions, additional questions, examiner always asks to give you bonus marks. As long as you are describing the findings correctly, so it's good. So never, we should never stress when we fail to, answer the secondary questions. Just concentrate on the next case. It would be fine. Okay. Yeah. If I tell you that this is an acute condition, I saw the X-ray of this female patient, 36-year-old, and in her previous X-ray, there was no widening. 1 year back. Okay. And now there is widening. What can you think?
Then it can be due to like traumatic cause.
Yes, traumatic cause. And secondly, because I still remember, you can see widening, maybe not that much, but still quite widening after childbirth.
Childbirth, yeah, parturition.
Yes. I saw one case during my on-call, and I ended up calling the whole hospital, the orthopedics and everything, that this is pain and fracture. But that's not so. The patient had delivered a few months, maybe a month back, and that is why it's perfectly normal, huh? Okay. This is well done. I'm going beyond my 5 minutes of feedback. Let us carry on. This was a very tough case in the sense that this is plain, but you did well. One thing which I would say, although Radiopedia has called it a biliary stent and saying that this is biliary gas, but somehow or other I cannot convince myself. It seems like a DJ or some misplaced sort of thing.
Misplaced stent. Yeah.
But let's leave it to that. Let's forget that this is here. But this is actually massively enlarged polycystic kidneys. And the other association which I was trying to find out from you was the intracranial aneurysms. A percentage of polycystic kidney disease can have intracranial aneurysms.
Yes.
Coming to the last case, look, this one, it was tough, so no issues. You picked up this properly. This was widening because this is sessile osteochondroma. This is part of sessile osteochondroma. This is sessile, like these are broad-based. You cannot see anything here, but even with this lesion, you do not see any periosteal reaction, right? No cortical destruction. It seems to be as out-pouching or projection, but it's not pedunculated. It's broad-based or sessile. Okay. When we come here, again, you correctly picked up. This is osteochondroma. This is osteochondroma. Okay. If I can show you, if I can convince you, even here, this is, this neck is widened. This is osteochondroma. This is osteochondroma, and this is malignant transformation of the osteochondroma, the chondrosarcomas. Okay. Flocculent ring and arc-like calcification. So here on the CT, what we were seeing was basically the malignant transformation of the osteochondroma. Okay. Maybe it came out from here, from the inferior pubic, from the posterior aspect of this pubic symphysis. But whatever the cause, this is a malignant degeneration. So it will go to the sarcoma center, and there everything will happen, right? We could trace the urinary bladder. So this was not urinary bladder, but this was a tough case. But ring and arc-like calcification, these are the words which we will use. One thing I just wanted to say, that there is a terminology which is used for for this sort of. God, I'm so sorry. Where did it go? This is what happens when there are too many.
For the which one? Sorry.
I'm showing you. Just wait.
Okay.
I've lost it.
Actually, the last osteochondroma in the pelvis, that was a osteochondroma turned into a chondrosarcoma.
Yes, yes.
Okay.
Just I wanted to show you this bull, this Brahman bull. This, it has a widened neck, and that is why that look of the osteochondroma in the neck is called Brahman bull appearance. Okay.
Good.
So thank you so much, Dr. Sayan. Thank you for. Can you see my screen?
Problem. Yes, I can see the bull still.
You can see the bull still. Okay. Okay. Thank you so much,
Okay.
Dr. Malik. Can you unmute Dr. Kamal, please? He's the next candidate. While I try to find where is my next case.
Hello.
Yes. Hello, Dr. Kamal. How are you?
I'm fine. It's
Sorry
very tough to manage after that much good candidate.
Good candidate, right? Yes, it's never easy. Dr. Sayan has been, he's a very good candidate, no doubt about it. I'm sorry, but I think I have some problem with my I have lost. Where is my? I will give you the screen. Just let me open my the one which is meant for you.
Okay.
It is not that it is meant for you. I mean, I made separate ones because otherwise it becomes difficult to keep the same one. Okay. Can you get the control?
Yeah.
Is it working? Okay. Is it working for me as well? Wow, that's good. Okay. Your first case.
I can't see the.
You can't? Oh, sorry.
Yeah.
Can you see now?
I have just the still screen at my.
Okay. I think I have not been able to give you the control. It's some setting on my part. Apologies. I'll check it next time.
Oops. Okay.
I'll do it for you. Go ahead.
I cannot see. I still have the still screen which shows multiple.
Yeah, I have a previous screen.
The screen is freezed.
Okay. Is it moving now?
No.
No.
Oh. Okay. Let me stop share. Let me start again. I'm sorry for this glitch, guys. Can you see it now?
Yeah.
Okay. What can you see?
So I am provided with the MLR view of the breast. Okay. The woman presenting for routine screening programs.
Yeah, 40-year-old. Yes, go ahead.
With the MLR view of the right breast and a magnified view, which shows the predominantly fatty breast tissue with scattered with minimal glandular parenchyma. I cannot see any definite worrisome calcifications or any microcalcifications on the magnified view as well. On the first look, there is no definite lesion I can appreciate. And the nipple is seen at the normal anatomical position.
Okay. Can you see anything on the magnified view?
You have changed it.
Yeah.
On the magnified view, I cannot appreciate any definite abnormalities still yet on the first look.
Okay.
There are few small tiny specks of calcifications, amorphous calcifications seen within the glandular parenchyma on the upper quadrant.
Yes.
Of the breast. However, I cannot appreciate any definite lesion in this region.
Okay.
On the deep look. However, as the amorphous calcifications are noted, so these are worrisome, and I would look the patient for the ultrasound if I can find anything. Otherwise, I will refer the patient to the breast surgeon for the to the interventional radiologist for the stereotactic biopsy and the triple assessment.
Mm-hmm.
And
Okay. I'm giving you the
yeah,
ultrasound.
okay. On the ultrasound, there is a lobulated hypoechoic heterogeneous lesion noted at the site of the interest, which is wider than the tall and
Mm-hmm.
is not penetrating deeply into the muscular planes. It shows lobulated margins and no posterior acoustic enhancement or any shadowing is noted.
Okay.
So the lesion appears to, and in the presence of amorphous calcifications and the provided ultrasound image, the lesion is malignant. I would like to put it in the Byrates category 4C
Okay.
and uh,
What
further refer the
else
patient.
will you do in your routine practice imaging wise?
Yeah.
I gave you only MLO and a magnification view, and I gave you a static view of the ultrasound. But in your routine
Yeah,
practice,
in routine practice, I will correlate my findings with the CC view and also assess the axilla of the patient
mm-hmm.
for the lymphadenopathy.
Okay,
And also, uh,
agreed. Anything else other than these two things you mentioned?
yeah, for the screening and other thing, we can also assess the contralateral breast for any
Okay,
additional lesion.
okay. Assess the contralateral breast. Anything else? You are doing good.
Yeah.
You said all the right words.
We also compare in the routine screening
Yes.
program. We can also compare. We will compare the mammogram with the previous.
Excellent. That is all we need. Okay. Your next case, Dr. Kumar.
So the lateral thigh pain, 50-year-old female.
Yes.
So
Go
I
ahead.
am provided with the radiograph hip joint, AP and lateral views, which shows there are the calcifications noted projecting within the left half of the pelvic cavity.
Mm-hmm.
The hip joint alignment is normal and the bone density is normal. Uh, there is slight decreased superior joint space. I cannot appreciate any definite lesion,
Mm-hmm.
and soft tissue appears to be grossly normal. Other than these calcification in the medial joint space, medial hip, okay, on the lateral view, these are projecting.
Describe
Oh,
the calcification for me. What's
yeah.
the shape of calcification?
Okay, the calcification appears to is a tooth-like appearance.
Excellent.
It's tooth-like appearance
Hmm.
and is projecting within the pelvic cavity. So I would it appears to be considering the shape of the calcification, and I will assess the patient in the ultrasound for the assessment of the most likely the dermoid.
Good. Okay, good. So you will go next. You will go for the ultrasound.
Ultrasound. I will assess the patient for in the ultrasound and confirm my findings of the calcifications and any cystic lesion with the cystic component and any soft tissue
What will
component.
you
If
do next after this? After the ultrasound?
I will convey my finding to the primary physician,
Okay.
and if any, as the patient is having pain, so I will also look for the torsion and associated complications, if any.
Okay. Good.
And if we found something, then we can refer the patient for the CT scan and
Yes. I mean, this patient will be referred to OB-GYN, right?
yeah.
Once we found that this is dermoid cyst, it's OB-GYN. Okay. You gave me one complication of dermoid cyst as torsion. That's good. Any other complication you can think of? One more even? Yeah.
Rupture.
Excellent. Okay. We'll move on to the next case.
Yeah. So the patient with Scandi fatality, previously given birth to a healthy child, 25-year-old female.
Okay.
So I am provided with the grayscale images of the ultrasound pelvis,
Mm-hmm.
which shows the I can see the two uterine cavities with the normal endometrial lining within the within the both uterine cavities,
Mm-hmm.
and normal homogeneous myometrium.
Mm-hmm.
I will assess further any other images. I will assess the cervix of the patient, whether whether there is any definite joining point in between the two uterine cavity inferiorly or not.
Okay.
And
You're thinking about what?
I'm thinking about the bicornuate uterus and uterine diadelphys.
Excellent. Okay. It's not very clear on ultrasound, let's say. And the patient has come to you with secondary infertility, right? So any other investigation you would like to do next after this ultrasound?
We can proceed with the hysterosalpingography for the further detailed assessment.
The HSG for you.
So on the HSG, I can see the cannulation of the cervical canal with the opacification of the both uterine cavity in the single go. And there is normal spillage, and there is opacification of the bilateral fallopian tubes noted with spillage of the contrast, which is very clearly seen on the left side. However, and I cannot see the free spillage on the right side in current examination in the provided images. However, minimal spillage is also noted on that side.
Okay.
But the two uterine cavities are noted with the single cervical canal. So my differentials would be, the possibility is bicornuate uterus.
Okay, I'll give you the next case. Okay, good.
Okay. No clinical data provided.
This was a mean one, huh? Oh, sorry. This is supposed to be during the feedback.
Yeah.
Okay.
So right abdominal pain in end-stage renal disease, patient on dialysis with tertiary hyperparathyroidism, 25-year-old male. Okay, so this is the radiograph abdomen showing scoliotic curvature deformity with there is diffuse sclerosis of the spine noted with the vertebral body heights are basically normal. There is no definite vertebral body collapse. However, the density is diffusely increased, predominantly at the end plates.
Okay. Anything other than the spine? You described the spine. Anything else you can see in the bones or the extra osseous areas? The patient has end-stage renal disease, right?
I can just appreciate calcified, a few calcifications projecting over the left iliac bone.
Okay, so what is it?
I would like to correlate with whether patient goes for the transplant before, or could be.
No, there is no, I'm not giving you, I'm the mean examiner. I'm not giving you the history of transplant, but there's a calcific focus here in the left hemipelvis. And the patient, in the history, they told you renal osteodystrophy. So what it can be?
I would assess in the ultrasound to look for any calcified renal transplant is the definite.
Okay, so you think it's
I cannot make any other.
Okay, I'm giving you a CT chest now. Which one would you like to see? There are so many.
Okay, the venous phase.
The venous phase. Okay, this is, let me take you up first. You're doing great, Dr. Kamal. Don't worry. This is hot seat. Whoever sits here and does the job is a hero. Go ahead.
Okay, so in the CT scan, I can see multiple expansile osseous lesions in the first look in the vertebrae as well as in the ribs at the costovertebral junctions.
Excellent.
In the posterior elements as well as in the multiple vertebral bodies. Both kidneys are very small, atrophic with parenchymal thinning scarring and bilateral prominent renal pelvises. Okay, and the calcifications projecting over the iliac bone, I can see within the There is calcified soft tissue density mass
Yes.
noted in the anterior to the psoas muscle in the
Yes.
left lower abdomen.
Hmm.
It is not continuing with the bowel loops, as well as no communication with the adjacent structures.
Excellent.
So it has no vascular region as well.
Okay, so this is?
This could be the extramedullary hematopoiesis, something like that.
Okay.
I can't make it. The rest are the brown tumors and multiple osseous
When I
lesions.
said I'm not giving you the history of transplant, doesn't mean I'm not providing you with one. But what do you think it can be in the end-stage renal disease? This is calcified transplant. You are right, huh?
Okay.
Even if I'm not, I mean, even if somebody gives you a plain with end-stage renal disease, that's what you should say first, okay? Have a look at the bone windows.
Yeah, these could be the multiple brown tumors within the bones.
Okay. Do you feel concerned with these brown tumors? The pattern?
Yes, as some of the are seen in the posterior vertebral posterior elements and within the vertebral bodies compressing the spinal canal and could have a compression effect over the cord. So I will immediately refer the patient to the neurosurgical consult and advise the MRI.
Okay, here's your MRI. Good. So this is what you have to say. Excellent. You know, when you have such, I'm giving you the sagittal directly for the sake of time. Okay.
Okay. So on the sagittal images, I can see multiple osseous lesions again. The one in the upper thoracic vertebrae and in the mid thoracic vertebrae, especially in the posterior elements, are compressing the spinal canal and having a almost moderate to severe compression over the cord.
Okay. So can you sum up everything now? Whatever you have seen on X-ray, on CT, and on MRI?
So the native kidneys are small, atrophic, with multiple brown tumors throughout the axial and appendicular skeleton. Some in the posterior elements and in the vertebral bodies compressing over the spinal canal and over the cord. So significant compression over the cord. Calcified renal transplant noted in the left hypochondrium. And so the findings are overall of end-stage renal disease with renal osteodystrophy, brown tumors, and compression over the cord. I will refer the patient to the neurosurgical team.
Excellent.
For the treatment.
You've got exactly 1 minute for this case, okay? Knee pain, 30-year-old male.
Okay.
Tell me which one do you want to see? I'm starting with T1.
Sagittal.
Okay?
Sagittal. Yes.
Okay.
Okay, so this is the MRI knee joint in which I can see there are multiple erosions noted within the tibial and tibia bone, and predominantly markedly hypointense T1 and T2 structures within the areas within the joint cavity, which are causing erosions over the bone, both anteriorly and posteriorly. Joint effusion is observed with multiple hypointense signal foci within them. And
so this is what? The first, the prime differential. Of course, you can give other differential as well.
The prime differential would be PVNS.
Good.
And the other, I would like to place the hemophilic osteoarthropathy.
Excellent. This is what I wanted to hear from you. Very good. So your 15 minutes are done. I think you did very well, just like Dr. Sayan. It's always, trust me, never feel, when you will look back, you will think about it. Oh, I knew this as well. And why didn't I say this and that? But trust me, it's just hot seat. Okay. Everybody else in the audience would be able to see what you in the hot seat will not be able to see. So considering that, you picked up all the findings and you described it well, so very well done. In this, I don't have anything to add. You described it as large joint effusion. Yes, there are multiple nodules which are low on T2 and T1, right? There are certain, there are defects in the lesions in the femur and tibia as well. This due to erosions, due to pressure effect. So this is PVNS, but the fact that it was 30-year-old male, I think hemophilic arthropathy or hemophilic, what I should say, joint effusion is a very reasonable differential. So this was good. The other one, this end-stage renal disease, you did well. It's always difficult on X-ray, but let's tune ourselves to this. Whenever we see any stigmata of end-stage renal disease, and we see a calcific focus here, or in the pelvis, or here, wherever, whenever we see a blotch of calcification, that's calcified transplant kidney, okay? The rest of the findings, yes, they were subtle, but if I can convince you, you see this rib, right 11th rib?
Yeah.
The density? Then here it becomes a bit loosened, then we again find it, right? So
Yes.
there's a sort of lytic lesion here. Then if I can convince you, look, these are lucent lesions here. Lucent lesions here, right? Lucent
Agreed.
lesion, right? So these are all brown tumors, which you correctly said. In the CT, I think you picked up almost all the findings. You correctly described it as atrophic kidneys and multiple, lucent lesions throughout, and the calcified transplant kidney. And what I needed to hear from you, which you correctly said, that the pattern of brown tumors here is concerning for cord compression, and you correctly asked for an MRI for it. So this was good. Okay. The next one, I'll first show you the case itself. You did well here. When you were saying the ultrasound, the fact, what Dr. Nadeem and Dr. Maheen are always saying, that we should articulate the thought process, even if you don't see it. So although you couldn't see the cervical canal, but you said it out loud, that I want to see that if there are separate cervical canals or not, right? This was good. This is what we have to do in the real exams. I agree. It's a bit difficult here to comment whether this is double cervix or not, but they have given it as 2 endocervical canals. So that is why they have given it as uterus diadelphys. But the way you were articulating, it's fine enough. That you are saying that because I think it's a simple cervical canal, single, so you were calling it bicarnuate. I don't think any examiner would, he would say that there are 2 and then you can go diadelphys. But it was,
on what basis they have said that there are 2? Because I can see.
Because I think they have done the case. I agree. It doesn't seem like 2 cervical canals, but maybe because they first cannulated 1 and then they went for the second. It's very hard with this, when once you have cannulated, it's not always possible to see the cervical canal very clearly. But I think it's more when they did it, and maybe they have other phases which they have not given to us. That is my thinking. But let me show you more here. This is normal, okay? Uniconduit, I don't think we would have much difficulty on it. This is something which we can understand. This is diadelphys, as you said, separate cervical canals, right?
Yeah.
This is bicarnuate, complete and partial. But here we have, here it's almost the cleft is going all the way down. In the bicarnuate, the cleft will not go all the way down. This is something which we'll be more able to appreciate on the MRI. The important thing which I wanted to show is the arcuate and the septate. Because the septate needs resection, right? When it's a cause of infertility.
Yes.
In the arcuate, yes. In the arcuate, there is a dip in the fundus, which is usually less than 1 cm. An arcuate usually doesn't cause that much of infertility problems as the septate because of the problem with implantation. So this is the septate, which has a dip greater than 1 cm, and differentiation is very important in this case. Okay, I'm reaching my 5 minutes feedback limit. Let me just hurry it up. This was good. This was the edge, what you would say left thigh pain, but you had to pick up this tooth, which you did. So this was good. The complications of the dermoid cyst, you told about the rupture, you told about the torsion, there can be malignant degeneration. So all was good enough. And I think what we need to know, which Dr. Maheen was emphasizing in my Viva as well, that I don't need surgical details. I don't need, clinical management details. What I need to know is the radiological and then referral. I think we can safely say that this is a dermoid cyst. And if the patient comes with pain, I would be referring the patient to OB-GYN and discussing with them the need for CT to rule out torsion. Like this, it would be good enough. Okay, this was the mammography, which you picked nicely, that this is a microcalcification. Okay, what is the size of microcalcification? It should be at least less than 0.5 cm, then we call it microcalcification. The rest, you rightly said, as I discussed with Dr. Sayan as well, all the things which we have to mention, the triple assessment, the axilla, and the referral to the breast surgeon. I think, yes, you did well. So thank you so much, Dr. Dr. Kamal.
Thank you.
Very well
Thank
done.
you.
Dr. Saneej, you can take over. And
yeah. Okay, thank you.
Yeah.
So who is the candidate? Hello, can you hear me?
Yes.
Yes, I can hear you. Just let me unmute Dr. Sahar. Sorry. Dr. Sahar, can you? Yeah.
Yeah, I can hear. Yeah.
Okay.
The only question is that, that we can get a mouse control, or the examiner is doing that scrolling.
Actually, I think let us try with Dr. Saneej. I think there is some problem on my settings end.
Yeah, this is my first time, so I don't know the system. So let's.
So I can give you remote control also.
No, it's okay. If I'm comfortable with you scrolling, it's okay.
No,
so,
I'm comfortable with you scrolling.
Okay, whatever.
In the real exam, you have to scroll.
Okay.
So there will always say
option
cheat
and I
if I
request
am
for the
scrolling.
control, right?
Yeah, your name. I can give you the remote control if needed.
Yeah, Sahar.
Sahar, okay, I'll give you. Okay.
Yeah.
So Sabahat, can you keep the timing now?
Yeah. So.
Can I start? I'll give you the remote control when needed. Okay.
Okay.
Yes,
okay.
Yes, Dr. Saneej, you can start.
Yeah.
So you can start. You can start.
Yeah.
Select decline your request.
Yeah, I'll give you whenever it is needed. Don't ask me. Like when the examiner give you the remote control whenever it's needed. You can't ask.
I'm ready.
Okay. So they will give you the mouse whenever it is needed to scroll. Okay.
Okay, sure.
Okay, you can start.
Okay. So this is the plain frontal. Actually, it's saying Dr. Saneej, decline your request.
I told you. I will give you the remote control whenever it is needed. You can start the examination. You can start saying. Why is the need for remote control in a plain field?
So the clinical history is about the diabetic patient with abdominal pain. So this is the frontal radiograph, and we see the further angiotuben in situ list. And if we look down in the pelvic region, there is a lucency completely surrounding the bladder area. And there is some airflow level with the air on the top on the bladder. Visualized bony structures appears unremarkable. In keeping view of the diabetic history, findings are mostly suggestive of emphysematous cystitis.
Okay.
So further, since the patient is kind of acute emergency, patient is diabetic, and this is kind of a life-threatening situation, we have to urgently refer the patient to urology for further assessment, for antibiotic cover, and further therapy.
Okay. Can you see the film?
Yes, I can see. So this is the extralateral cervical spine that is showing that some luxation seen at the level of atlantoaxial luxation. However, the rest of the cervical vertebrae and their anterior spinal, posterior articular spinal lines appears they're well maintained. So, in keeping view of the history of road traffic accident, most likely suspicious is for the injury at the level of atlantoaxial level.
Okay, so what will you do?
I want to see that open mouth view for articulation and the fracture of the C1 and C2 level. So in this open mouth view, there is some asymmetry that is seen between the C1 and C2 on the right side with suspected fracture of atlas on the right side.
Okay.
So I will further proceed since it is an acute emergency with RTA. Would need to do the CT to look for the further articulation and for the possible impingement on the cervical canal. And yes, so this is actually C1 vertebrae is basically a ring. So if one anterior.
Now I have given you the remote control, so you can scroll.
Okay. Hold on. I don't know. I think it's stuck. No, I cannot scroll it. Sorry.
You can keep the mouse over the arrow. Don't double click.
Okay.
Okay.
I think if you do it better, I think I am not just.
Don't click twice. You can just keep the arrow here and go up and down. Otherwise, no other movements.
Okay. Yes. Yeah.
Just go up and down.
Yeah. I think it's better if you do it because I think I'm stuck with it. I cannot do it. So I'm giving up the remote to you. Now you can scroll. Sorry for that. So the CT axial section, on contrast CT cervical spine axial section showing the displaced fracture of C1 vertebrae, and with the foraminers are patent. I don't see any other fracture. The other vertebrae I cannot see on this view. So most likely this is the C1 displaced fracture of anterior and posterior arch. Since it is a ring vertebrae and one arch fractures, then it is the fracture on the other side, like in a pelvic fracture, there are ring fractures. So this is kind of an acute emergency. Patient, actually in these images, I cannot see the proper impingement on the cord. So the clinical history is important, and then further referral to the neurosurgery for further assessment and immobilization and treatment.
Okay.
And one more thing, because sometimes if the vertebral foramens are
your
involved.
case is over. Your case is over. So you have to take another case. Okay.
Okay, see, this is X-ray frontal projection, predominantly showing the bones. So I can see some clips around D12 on the left side. With some, there are some lucencies seen at the level of the pedicle of D11. So I just need to have look for the clinical history of the patient and review some previous films available, and for the labs.
Yeah, they had previous surgery.
Previous surgery. So if there's kind of some malignancy, so possibly that this is the arterial lesions involving the pedicle of this particular vertebral body.
Which vertebral body?
This is D11.
This one?
Yeah. No, this is the gas shadow. Sorry, this is gas shadow actually. I think this is the overlying gas shadow. So apart from these surgical clips, which in keeping with the previous surgical history, I don't see anything specific in this film except that left kidney shadow is not visible clearly. Right kidney soft tissue shadow I can see, but left I cannot see. Visualized bones shows this abnormality.
So what will you do?
I would further look for what kind of surgery patient has undergone, and then further depending upon, because is there any obvious clinical history by the patient?
Yeah, with the so far findings that you have given, what surgery that might have been had?
Most likely the renal surgery,
Yes.
nephrectomy.
Yes. You told
Yeah.
the correct points.
Yeah. So maybe renal cell carcinoma, or obviously renal cell carcinoma. Yeah.
Definitely.
So definitely I would be looking for some osteolytic metastasis in this case.
So what will you do when you are stuck?
I further go for further imaging like CT.
Before going to CT?
I can do the bone scan for looking for any, but usually the renal CAs, they are osteolytic. So most likely they would not give or do the complete.
Before going to the bone scan?
I would look for the another view of the X-ray to see the padding.
Definitely. Definitely.
So yes, I can clearly see that G11 is collapsed. It's loosened. So this is the Philida fracture involving this G11 vertebrae. D10, sorry.
Okay.
Yeah, D11 and D10. So most likely it's an osteolytic secondary to the renal cell carcinoma involving the left kidney. So I have to, since patient is a known case of renal cell carcinoma in keeping view of the left nephrectomy. So it's, if there is no previous film showing these findings, so it's a new finding, it has to be urgently conveyed to the urology or the oncology team with further MDT, further evaluation with the bone scan, then CT, chest, abdomen, and pelvis for further evaluation of the further metastasis.
So, this is the CT. You can try clicking only these arrows.
Yeah, I tried, but actually I don't know what happened. I am not able to do it. Yeah, I was trying to do it. Let me see if I can. Yeah, it changes the screen, but it doesn't help me. So there is a fracture involving this L3 vertebrae with the paraspinal component. Most likely there is some paraspinal component, soft tissue density I can see on this bone window. So there is an impingement of the spinal canal. If the patient is presenting with neurological symptoms like paresthesia and the limb dysfunctioning or something, so it is an acute emergency, should be referred to neurosurgery for this particular findings.
Okay, then?
An MRI should be done, so further evaluation of the soft tissue component, spinal cord, and yeah. So if we see in the MRI, this is a sagittal T1 weighted images that is showing the complete replacement of the fatty marrow of the L3 vertebra with I don't think so. There is possible fracture, and there is a soft tissue component that is impinging of the cord at this level. And there are few vertebrae that are seen. The thoracic spine also shows the multiple deposits. Contrast. This is on a non-contrast.
These vertebrae. Are you talking about these vertebrae?
Yes.
So then these vertebrae are similar to this vertebra?
No, there is a difference. No, there is a difference. This is a complete replacement, hypointense. They are kind of, but here again, if you see the fatty marrow is not preserved in the upper thoracic also.
So which one is abnormal here? Can you point out which one is abnormal, which one is normal?
Like this one, these ones.
You can click.
Okay, this, and this upper thoracic.
They are abnormal.
No, basically this is abnormal, but I think there are some kind of changes in these vertebrae. Maybe they are not infiltrative, maybe because of some metabolic reason or something. But this L3 is metastatic with some soft tissue component involving the spine, spinal cord, impinging the cord at this level.
So what about these vertebrae, like these vertebrae?
Maybe this is age related. There is some changes that is not completely. Ideally, the marrow of the vertebral body should be completely fatty. So there is some replacement of that fatty marrow here, but doesn't look like a metastatic as in L3 vertebra.
Okay. Can you please? Okay.
We can compare with the star images or some other images if for further confirmation. Okay, so this is the breast CC view that is showing a well-defined lesion in the outer quadrant of the breast that is showing heterogeneity um, and showing a mixed hyper radiodense and lucent areas. It is well defined. The surrounding parenchyma doesn't show any architectural distortion. There is no skin thickening. Their nipple seems to be normal with no retraction. There are no obvious, there are few tiny foci of calcification within it. There is no other obvious pathology in the rest of the breast parenchyma. In keeping view of on my findings on the single CC view, most likely it's a benign lesion, likely hamartoma, or it can be a phylloid also. Further axillary MLO view would be needed for further evaluation of the axilla and further assessment with clinical assessment. There is one benign looking lymph node seen in the axillary region. So there is no obvious malignant lymphadenopathy. Further assessment.
Excuse me, 15 minutes are over.
Okay, okay. Okay. So, Dr. Sahar, how did you do?
I don't know. It was my first time.
Yeah, okay. So what you have to do is whenever you have shown a case, you have to repeat the clinical history. So what happens is when you are repeating the clinical history, you will get time to review the images for a while, and you will get some time to see the images, and you will get to know the history. The history will be planted in your mind very well. So you are not repeating the history. Second thing is otherwise you are good, but you have to use some buzzwords like breast in a breast appearance. Otherwise your diagnosis here is correct and your approach was good in this case. And you told about the triple assessment, then you will be shown this ultrasound. And this case you correctly pointed out that there are surgical clips at the level of T11, L1 and T12, L1 and all, and you are not seeing any renal shadow. So you have to point, but you have to tell that I am suspecting a renal surgery, and a radical nephrectomy usually happens in a renal cell carcinoma, and I am looking for any lesions like most commonly the renal cell carcinoma shows lytic lesions. I am looking for any lytic lesions. And when you are stuck in a film, then you have to ask for the another view. Like automatically you have to ask in my what you are doing in your normal practice, you have to emulate. Like in my normal practice,
Dr. Saneet, we can't hear you.
Hello. Can you hear me?
Yes, now we can.
Yeah, now we can.
Actually, you can see the compression fracture of this T11. Then also you can see some trabecular thickening and some lucency in the L3. So you correctly told you will compare the previous films, and you ask for a CT where you can see the compression and lytic destruction of the L3 as well as the T11. And you correctly pointed out the extradural component that is compressing the spinal canal. So you need a MRI. You ask for an MRI. So you have to ask for the previous films also, where you can see this is an old lesion and the L3 lesion was a new one. So this was a CT 4 years before. And in the MRI, you have to ask for other sequences before the film goes down. So you ask for the stir and roll after the film was.
I forgot. I forgot.
Yeah, actually, usually in your normal practice, you have to say like, I will see all the sequences in the MRI. Then only they will show you the other sequences. And once the film goes down, that case is over. You don't stop talking about that case. And here actually in a nephrectomy case, this patient had a radiation. So you can see the fatty replacement of the vertebral bodies due to radiation. So usually the iatrogenic causes will be sharp margins, like here only the areas which have got the radiation where you can see the fatty replacement. And here you correctly pointed out the marrow replacement by the metastasis and the collapse of the inferior end plate, and the you should have asked for the contrast. Then you can see the enhancing component that is projecting into the epidural space, and also the involvement of the T11 vertebra. So
yes, contrast.
Yeah, you could have asked for the contrast stereo images and all. Only if you ask, you will get the films. Otherwise, you will not get the films.
Okay.
So here, this was a cervical spine. You correctly, your approach was good. You told like I will be looking at the anterior spinal line, posterior spinal line, spinolaminar line, and also I'll be looking at the prevertebral shadows and any widening. And you correctly pointed out that the atlantoaxial distance is widened. So normally the adult it is less than 3 millimeters. So it is obviously enlarged. So you are suspecting some fractures, and you ask for the dense view, the open mouth view, where there is loss of alignment between the lateral masses of the atlas and the axis, and there is widening between the lateral mass and the dense. So obviously there is something happening with the ring of the C1. So you are suspecting a fracture, and you correctly told that you will inform the referring clinician and will arrange for an emergency CT. So in the CT, you can see the ring is broken at two locations, so anterior arch and the posterior arch, and there is an avulsion fracture here. So there is a transverse atlantal ligament here, which was fractured, and this is a chip coming from here. You can see this is the location where the chip is coming. So otherwise, it will be managed conservatively, but when there is a ligament injury with an avulsion fracture, it becomes unstable, and it is to be surgically corrected. And so
okay.
And is a diabetic patient with acute abdominal pain. So you have to repeat the history, and you correctly pointed out there is emphysematous cystitis, and it's an emergency, and you will refer to the urologist and all. So that's good.
Okay. Thank you so much.
Okay, welcome. So what next, Sabat?
Dr. Malik, if you could unmute yourself.
Yes, please. Can you hear me?
Yeah, I can hear you. So next is Malik, right?
Yes.
Okay. Sabat, can you please keep the timing?
Yes. Start, Dr. Malik.
Yeah, okay, you can start.
Vague abdominal symptoms for investigation, 75-year female.
So I have given you the remote control.
I can't.
You can use the up and down arrow at the lateral, the left lower part of the screen.
I think it's not speedy. It's like it's taking long time.
So instead of using that, you can use this arrow at the lower part, the lower quadrant, left lower. Yeah, just click the up and down arrow.
Okay, fine.
Yeah, don't move your arrow anywhere else. Just click there.
Okay, so that's the CT exercises non-contrast images. It's very slow actually. So I can appreciate there is irregular calcification involving the it's not moving actually. Sorry.
Yeah, I'll do it. No worries.
Thank you.
So you can Okay, 1 second.
Next time we'll practice before the session.
Yeah, no,
Okay,
I
okay.
know that, but it's very slow actually.
Okay, okay. I'll move from above downwards.
Right. Okay. So that's the CT axial SASI non-contrast images of the abdomen. I can appreciate there are some calcified lesion involving the liver, spleen, and yes. Okay. So I can also appreciate the irregular calcification involving the left kidney, and it is like showing irregular margins. No corticomedullary differentiation is absent. However, no evidence of any perinephric stranding or collection. However, the contralateral kidney is normal. So in the pelvis, yeah, I want to see the bladder.
Yeah, forget about the pelvis.
Okay, fine. So in keeping with the history of 75 years female with abdominal pain, I'm concerned about the tuberculous kidney, which is showing the irregular calcification of the and distorted left kidney. So, and I can also appreciate the calcified lesion in the liver and spleen as well. So it could be a possibility of TB deposit in the liver and spleen. So it's a chronic tuberculosis case. I will look for the bone window to look for
So
any.
yeah. Do you think it's active?
No, it's not active.
Okay.
So
Okay. What will you do?
I will look for the bone window as well. I need associated spondylosis.
Okay, bone window is normal.
Okay, fine. So I will refer this patient to the urologist and for further evaluation. The pain around left knee joint, 20-year male. Okay. So that's the frontal projection of the knee joint of skeletal patient, in which I can see there is a tubular lesion involving the metaphysis of the tibia with the surrounding sclerotic margins. It's a narrow zone of transition. There is no evidence of involvement of the epiphysis or is passing the growth plate. So there is evidence of, I can appreciate there is slight evidence of epiphysis, and while the distal part of the femur looks okay, no involvement of the joint space, no surrounding or soft tissue. The fibula appear normal. I will go for the orthogonal view to confirm my finding. Okay. Yes, so this is confirmed on the lateral view as well. That's the tubular lucendium. In keeping with the history of pain and young adult. So it's a case of the Brody's abscess. I will refer this patient to the orthopedic surgeon for the drainage. Left flank pain.
So here you can just try scrolling
Yes.
by using only the up and down arrow.
Right. Okay.
Maybe using the keyboard would be easier.
I did.
With the keyboard up and down. Does it work with
Yeah, you keep your mouse there and don't move, don't click inside the window, just the arrow.
Yes.
Yeah.
Okay. So that's the this CT exercises, photovenous phase. Abdomen shows large soft tissue density, mass lesion involving the retroperitoneum, which is displacing the aorta. I want to look for where I'm going up. So bilateral kidneys looks fine. I can see there is a displacement of the aorta towards the right side. looking at the, yeah, there is there is a hydronephrosis of the left kidney. Spleen and liver appear normal. I want to look for okay, in keeping with this soft tissue density mass, my first differential will be either is as in the retroperitoneal region. I want to look for the coronal images as well.
Yeah, you can look at the coronal.
Okay, so again, I can find that there is a large soft tissue density mat in the retroperitoneal region. In the could be and it's causing hydronephrosis. However, there is a lateral deviation of the hydronephrosis, so retroperitoneal fibrosis is less likely. It could be a lymphoma in keeping with the history, but I want to look for other lymph nodes as well.
Okay. You can use the up and down arrow at the lower part.
Up and lower part. Okay. So okay, I'm suspicious about some mass lesion involving the left testicular.
Okay.
So in keeping with this, I'm not sure because I can't appreciate clearly. I will go for the ultrasound correlation as well.
Okay. Can you remove the mouse? Can you just leave the mouse?
Yes.
Okay. Okay.
Okay, fine. So that's the left testicular mass that's surrounded with the heterogeneous appearance. I want to look for the vascular images as well. Yes. Okay. So there is an internal vascularity. However, it shows the rounded walls with the slight thickening of the thigh, and it looks like the heterogeneous. No evidence of any cystic component. And so I will, in keeping with these all findings and including the summary, my first differential practice is the testicular carcinoma with the retroperitoneal lymph node adenopathy. Or its other differential could be lymphoma. So I will.
So what was the age of the patient I given you?
It was 14, I think. I'm not sure. I forgot that.
Yeah, you should not forget, because you have to tell the differential diagnosis according to the clinical history.
Yeah. It was 30 years.
So do you have the lymphoma still in your differential diagnosis?
So it's a seminoma with the lymphadenopathy. So I will correlate. I will alert this case and refer this patient to the MPC discussion of urology, and I will ask for AFP related and other left correlation. Painful right knee following twisting injury 10 days earlier, 25-year male. Okay, so that's the lateral view of the knee joint of the scalping patient of 25-year-old male. So I can appreciate there is a slight in keeping with the history. There is indentation of the.
Can you speak to the mic, please?
Yes. In keeping with the history, I can see there is an indentation of the medial condyle on the lateral view. I will confirm yes on AP view as well. I want to see the AP view.
There is no AP view. Can you just point out what you are saying? Click and point out.
I think there is a hump or indentation of the medial condyle.
Okay.
So no evidence of any soft tissue swelling or any joint or cortical break. I can appreciate. Rest of the tibia and fibula pretty normal. Patella in the normal place, and distal part of the femur appear normal. So further to confirm any ligamentous injury or other with the joint pain, and to look for meniscal tear, I want to look for, I will go correlate with MRI imaging.
Okay.
So okay. So that's the PD fat set. Sagittal imaging, in which I can see there is a joint effusion. Sorry, you can. Okay, so the marked abnormality I can see is there is a distortion of ACL, anterior cruciate ligament. It's not staying over there. It's moving. Yeah, and I can appreciate, I want to look for the star imaging as well to look for bone edema.
Okay.
Yeah, that in which I can see there is a complete distortion of the ACL, and I want to look for any buccal handle here of the medial meniscus. And
can you speak to the mic, please?
I want to look for any buccal handle here of the medial meniscus.
Yeah,
well.
okay, menisci are normal.
Menisci are normal. Posterior cruciate ligament also appear normal. So I want to look for star images to look for any bone edema.
Yeah, can't you see the bone edema in this image?
I can appreciate, but I was confirming. So there is specific bone edema with the ACL here. So that's an emergency, and I will definitely refer this patient to the orthopedic surgeon for fixation and for the surgical.
Okay.
So no history there. So there are multiple. I can. This is a coronal view.
Dr. Amara, your voice becomes muffled again and
Yeah,
again.
you can speak to the mic. You are speaking away from the mic.
Is it now? It's clear.
Yeah, now it's clear. You are often.
Okay, that's the coronal images of the CT abdomen, in which I can see there are multiple low density lesion involving the bilateral kidneys, and kidneys itself are enlarged in size. I can appreciate there is no evidence of any perinephric collection or hematoma formation. Is it movable?
Yeah, you can control.
Okay. So I want to look for any perinephric collection, no evidence of any perinephric collection.
You can scroll by pressing that arrows. Okay.
Dr. Saneesh, 15 minutes.
Okay.
So low density lesion, I want to look for the pancreas as well.
Because we lost some 1 or 2 minutes by scrolling, can you just summarize the findings and give a diagnosis?
Fat density lesion involving the bilateral kidneys are referred to as angioedema. Bilateral angioedema, as is involving both of the kidneys. I will concerned about the tuberous cirrhosis, so I will look for other. I will go for other imaging as well to look for chest.
What imaging?
Sorry, chest imaging and as well as brain imaging to look for the tuberous cirrhosis.
Okay. This is the brain.
Yes, so that confirms that there is a subepidermal calcified nodule along with the cortical tubers on the CT non-contrast images. So I want to look for any giant cell astrocytoma associated with, but the no evidence of a hydrocephalus or giant cell astrocytoma on this image. So
Okay.
that's confirmed that's the case of tuberculosis. I will refer this patient to the I will refer my findings to the physician and ask for heredity screening as well as the follow-up scan to look for any complication of angioimlar tumors if they are more than 4 centimeter.
Okay. Okay. Fine. So here your presentation was good. You picked up the multiple angiomyolipomas. They are bilateral and multiple numerous. So in such cases, correctly, you have to raise the possibility of tuberous sclerosis, because sporadic will be usually one. But if you're seeing multiple, you have to think the possibility of tuberous sclerosis, and you have to search for other stigmatas of tuberous sclerosis in this case. And you have to check for the previous images and ask for the history, whether this patient has any seizure or any mental retardation. So this patient came with seizure and mental retardation. Then you have to ask for the CT brain, where you can see the calcified tubers, subepidermal tubers. So, and you have to say that there are no giant cell astrocytoma now, but you will, as you told that you will follow up the case, because any of these lesions can degenerate into the giant cell astrocytoma. So you also told you will look at the chest and will refer this patient to the, since the patient came with seizures, you have to refer this patient to the neuro. Depending upon the history, you will refer. So this 25-year-old with knee injury. So you have to ask for a orthogonal view. You asked, but there was no orthogonal view. And you correctly pointed out the lateral femoral notch sign here. And there is a knee joint effusion that you have missed. So you have to tell the knee joint effusion also. And you have to alert the referring clinician about an internal derangement of the knee, especially any ligament injury. This lateral femoral notch sign is usually seen in ACL injury. So you have to specifically say that I look at the ACL and I have to see the MRI, and you have to use buzzwords like the typical kissing type of contusion. And you have to say like, my finding in the X-ray is confirmed in this MRI with the lateral femoral notch. And otherwise, your findings were good, like there is complete disruption of the ACL, and that was no more parallel to the Blumenstadt's line, and it is not continuous diffuse edema, so it's a complete rupture of ACL. So you have to refer this patient to the ortho. That also you told. And this came with the left flank pain. So this is where we are giving the mouse control to you, because if the examiner is calling, then you will not, because then only you will find out the corner of the film findings. It is a corner of the film, a typical FRCR film, where the finding will be at the corner. So you correctly pointed out it, and it's a age is a matter, like it's a 30-year-old male with left flank pain. So you have to repeat the history, and you have to remember the age of the patient, and you have to give the DD which is applicable for that age. And here it is most likely a seminoma, because a seminoma, it will not metastasize to the inguinal node, it will not metastasize to the pelvic node, it will directly go to the nodes at the level of renal kidney. So because of the lymphatic drainage, and you have to ask for the ultrasound, and ultrasound you found out there is a mass with increased vascularity, and you have to tell that I am suspecting there's seminoma with metastasis. You should not give the DD of lymphoma because already the age has been given.
Yeah.
And in this case, 20-year-old male with the pain around the left knee joint, that case you have to refer to the urology MDT also, that you correctly done. So this case you did well. It was a Brody sepsis, and you referred it to the orthopedicians. So don't tell them about aspiration and all that, they will decide. You just refer to the ortho. And vague abdominal symptoms for evaluation, 75-year-old female. I think this was the first case. So the point that you have to tell is it's a burnout tuberculosis, like it's a inactive tuberculosis. It's a tubercular autonephrectomy or putty kidney. So you are telling like tuberculosis of the kidney. So that will give a notion like it is active. So you have to tell that these are all chronic. Finally, you told that it is chronic cases, chronic tuberculosis disseminated tuberculosis involving the spleen, liver, and kidney and all, but that is not active now. So that's why. So that is good. This was the first case, right?
Yes.
Okay. So Sabat, can you hear me?
Yes, Dr. Saneej, I can hear you.
So is there any time?
It's 35. What do you say? We can take one more if you are okay.
Yeah, yeah. Okay. Is there any other? There are two more candidates, right?
Yes, there are two more candidates.
Okay, we can take one or two depending upon the time. So I'll share my screen.
Okay. I'll let Dr. Afsha.
Hello.
Yes. Okay, good. While you are sharing, just a few things, Dr. Saneej. Let's make it a habit from now on. We have to be very, very polite with the examiner. There is something which we do unintentionally. I was attending one session which was being for the local residents, and the examiner was very kind, but we tend to, in the heat of the moment, we tend to say, we can't, it's very blurred, the quality is not good, or don't try to use these words, and be very, very polite with the examiner. We have to get with it. He has your future in his hands. Please go ahead.
So are you keeping the time, Sabah?
Yes, I am.
Okay, thank you. You can start.
Yes, this is child with presenting with motor vehicle accident. This is X-ray neck, cervical spine, lateral view. Here I can see the anterior spinal line, posterior spinal line, articular pillar line, which are normal, but there is some widening of the spinous process between C1 and C2, fanning of the spinous process.
Okay.
And I think, and what I can see is that there is mild widening of the predental space as well.
Okay.
I can see that there is some, I think there is some irregularity anterior to the dens. This, I would like to see the open mouth view if that is available, or another view.
That was non-contributory. Open mouth view was non-contributory.
Okay. So in the prevertebral space, I cannot see any swelling.
Okay.
This is ET tube and no foreign body or any avulsed fragment noted.
You look at the bones, forget about the soft tissues.
Posterior to the C1 vertebral body, there is mild swelling. Otherwise, the prevertebral area is normal.
You look at the bones, you forget about the soft tissues.
Okay. So, concluding my finding, what I can, there is fanning of the C1 and C2. So, I am suspecting some anterior listhesis or some C2 fracture, maybe dense fracture. However, I cannot see any lucent line passing.
Dense is fine.
Okay. So now I'm looking at the skull visible, which appears to be normal to me.
Skull is okay.
I cannot see anything else in this.
If you are stuck, you can tell that I would like to skip the film and see the next film.
Okay, I would like to skip
then
that.
like that, you can save the time.
Okay.
You want to skip this?
Yes, I would like to skip that.
Okay.
Adult who has normal breast exam, mammography screen, female. Okay. Adult female, CC view, what I can see is that this patient has normal ultrasound and
No, I didn't say normal ultrasound.
normal examination. Okay, normal examination with no lump visible, palpable. There is some speculated area
Yes.
lesion with irregular or speculated margin noted in the center of the breast.
Yes. Yes.
And I cannot see any microcalcification. Maybe I can visualize that on the magnified view.
Okay, good.
This is a speculated mass noted in the center with no area of, there is one large calcification noted in the outer quadrant.
This one?
Yes, likely to be benign one.
Leave it.
Yeah, okay, no skin thickening or nipple is not normally visualized. Maybe this is retracted, but no skin thickening is visualized. To me, this is BI-RADS 4. I would go for the triple assessment. And so on ultrasound, this is a Doppler image. This is irregular speculated lesion noted with some faint calcification within it, and no significant skin thickening. As this is only the breast image, I've in my normal practice, I look at the axilla and scan it also.
Yeah, axilla is normal.
Okay, axilla is a normal. So this is an irregular speculated mass. So to me, this is now a BI-RADS 5, and I would like to go for a biopsy or refer this patient to the.
So this patient had a motor vehicle accident.
Okay. The patient X-ray hand frontal projection. I can see there is triangular shaped scaphoid, and there is some overlapping of the proximal row of the wrist to overlapping towards the distal row. Rest of the bones, I'm looking at the metacarpals.
Your good name?
Afshan.
Afshan, okay. Can you just point? I'm not seeing your name here. Your age? Yeah. What's your name given in the screen name? What's your screen name?
Afshan. AFSHAN. There is a raised hand against it.
I cannot give you the remote control.
Okay, I request you.
Can you request?
Yes, I send you.
Yeah. Can you just point out what you are saying?
This is. Can you see my?
You can click and point out. First you click, then you point out. Okay. Now you don't click. You just point out.
Okay. This is triangular shape, and there, I can see, there is overlapping of the scaphoid over the capitate, and as well as the lunate over the capitate, and there is also a proximal dislocation or subluxation of the fourth metacarpal, fifth metacarpal.
Okay. You can see the what will you do?
Lateral view. I would like to see the lateral view first.
See the lateral view.
Okay. In lateral view, what I can see is that there is volar tilt of the lunate, and the scapholunate angle is
lunate. That's fine.
Okay. That is fine.
Yeah, you can look other areas.
Okay.
That's not a true lateral. You can look at the other bones here.
Other bones, okay. I'm looking at the other bones. What I can see is that there is proximal displacement or movement of the fifth
Okay,
metacarpus.
okay. Leave the mouse. Leave the mouse, please.
Okay, I'm leaving it.
So what will you do?
I will go if the patient is still have pain.
Yes,
And
patient is having pain.
patient has motor vehicle accident. Maybe
Yeah.
we will go for an CT scan to see any other.
Before going to CT scan?
Some other images, some other view.
Okay.
Okay. 75-year male, lumbar back pain. This is bone window CT scan, sagittal reformatted sequences. I can see there.
You can click the up and down arrows.
Okay. I'm looking at the I'm looking at the sagittal section, reformatted image bone window. I can see there is the heterogeneous trabeculation and density of the L4 vertebral body, and there is some error also noted within the within some of the intervertebral disc.
Yeah, forget about the degenerative changes in the disc.
There is heterogeneous texture of the posterior element as well, heterogeneous density of the posterior element as well, of L4 vertebral body, of L4 vertebra. So this is an heterogeneous vertebral body with no collapse, and it is maintaining the normal shape and contour with no paravertebral or prevertebral collection apart from aortic calcification. I think there is some bulge, maybe no.
Forget about the disc. Forget about the disc.
Okay. There is no anterior or posterior listhesis. So, looking at one vertebral involvement, which is heterogeneous, some lytic area and some sclerotic area in the vertebral body as well as posterior elements. Involving the can I see the axis section as well?
Sure. You can take the axle.
So this could be a hemangioma, as this is not causing any ballooning, but the appearance it is giving. This is heterogeneous.
So you can move up and down.
Okay. I can't.
You can click and first you can click and move. Okay.
I am looking at L4 vertebral body, L5 sacral alas. Oh, I can see some more lytic and heterogeneous lesions, noting in the iliac blades and sacral body. So multiple areas of heterogeneous signal. These could be some metastatic deposit. Other differential could be.
Can you see the soft tissue window?
This is soft tissue. No, this is bone.
Yeah, the same window, the window that you have taken, and you concentrate on the L4 vertebra. Not bone window. That's bone window.
Okay.
So by looking at the vertebra, do you still think it's metastasis?
Initially, I was thinking of some sclerotic, like hemangioma sometimes becomes sclerotic, or lymphoma.
Yeah, will the
give rise
hemangioma
to
affect the posterior element also?
sometime, but when it is very big and it is expansile, it can involve
Is
the
it
posterior
expansile?
element.
Is it
No, it
expansile and
is. It
aggressive?
is not. It is not.
Okay.
No, I don't know. Maybe some
Okay.
depositional disease.
Okay.
Right loin pain. No that is applied.
Okay, you can scroll.
Okay. I'm looking at the CT abdomen, contrast enhanced images at the level of the kidneys. Okay. What I can see is that there is low attenuation lesion or non-enhancing lesion noted in the right kidney. Now I'm looking at the renal. I cannot scroll it.
You can just click the arrows only. You can click the arrows only.
It's tough when you are doing. Okay. I'm looking at the renal vein. I think there is filling defect in the renal vein as well.
Yes.
So this is focal. This is the this could be, as there is no perinephric standing, so this is likely to be a renal vein thrombosis causing a focal non-enhancing region.
What will you call that region?
Renal infarct, focal renal infarct.
Okay.
Yeah.
Then?
I will inform the referring clinician about the findings that there is a thrombus in the renal vein, and I would like to see either there is any other area of thrombosis like IVC or any extension of the thrombosis seen. And we'll look for the cause, as there are no other cause of renal vein thrombosis except from this is noted here.
Each 15 minutes are up.
Oh, okay. Sorry.
Initially, I quit the case. Maybe that was, I think, I guess it when I put the case down. That was case of, I think.
1 second. Can you please wait for a few seconds, because I'll join within few seconds. Sorry. Apologies.
Sure. No problem. Dr. Afshan, how did it feel?
What can I say if I lost first case?
No. You know, it's
my morale go down.
That's what we have to practice. That's what we have to practice. Every case is a new case, and it's always better to do your mistakes on these preparatory hot seats, so that we don't do the same mistakes in the real Viva. It's tough, but
I think first case was occipito-atlantal dissociation, maybe.
And do not think about the next previous case when we are doing the next case.
That's
this
the
is
dilemma. That's the dilemma of.
Yeah, that's why we are practicing. No worries. We all do that. Similarly, I'm also very bad at remembering the history, which is very important. And the examiner does not like to repeat the history. So yes, these are a few things which we have to practice, asking for previous, asking for other views. Dr. Sunil is back.
Yeah, apologies. So you did well. No worries. Okay. So in this case of right loin pain, you correctly pointed out there is a wedge-shaped area of non-enhancement in the kidney. So you are not using the term infarct until I prompted you. So what will you call that area? So you have to use the term infarct, and you correctly pointed out the renal vein thrombosis, and you told that you will refer and you will find out the causes of the renal vein thrombosis, and you look at the IVC and will evaluate the patient. So you will ask the referring clinician to evaluate for the cause of the renal vein thrombosis. So that is good. And regarding this lumbar back pain case, so here actually some sclerosis, there is some cortical thickening. So there is some trabecular thickening, that is involvement of the posterior elements that is a bit expanded. So this vertebra also a bit expanded. And I told you to look at the soft tissue where you can see the marrow fat is maintained, that is not infiltrated. So that rules out metastasis because the marrow fat is clear here. So, and you correctly picked out the involvement of the ileum also. That is also, there is cortical thickening, the trabeculae are accentuated, and there is some sclerosis, and you have to look at the patient's age, which is 75-year-old.
Yeah.
Yeah, so that is a usual time of Paget's disease. So it is a case of Paget's disease with the picture frame vertebra. So you can see the zoomed images here, and you can see the fat that is not infiltrated. So then you have to refer this patient to the orthopedicians for further management, and you have to compare the previous images also. And here, what we have to see is you have to see the arches, like there is some Girulia arcs 1 and arc 2 and all. And you have to also see the lazy M. Here, the lazy M is broken. So here, actually, this fifth metacarpal should have been articulating with the hamate here. So it should be sitting here. So instead of that, it is sitting over this tricutril. So that is this fifth carpometacarpal dislocation. So that you can see in the lateral also. You correctly pointed out that it should be overlapping. All these metacarpal should be overlapping. The bases should be overlapping. So one metacarpal is sitting anteriorly. The base, that is fifth carpometacarpal dislocation. So you have to refer this to the ortho because this patient came to the ED. So I was asking you, what will you do? So before going to the CT and all, you have to refer this patient to the ortho. So they have to decide whether a CT is needed or not. Otherwise, they have to do corrective reduction and all. So you just refer to the ortho. That you didn't tell. Otherwise, it was good. Then adult who had a normal breast examination, mammogram screening study. So it was a normal breast local examination. So you correctly pointed out there is spiculated lesion, and there is some radiating bands and all. And there is centrally, there is some lucency. Centrally, you are not seeing any mass here. So ultrasound, you can give the Byrad's category 4 here. So here there is no vascularity, and centrally there is some hyperechogenicity. You can correctly give the Byrad's 4, and this patient definitely needs biopsy to rule out a malignant lesion. But unless otherwise proved, it is malignant. But it was a case of radial scar. So in the radial scar, you can see some lucency in the centrally with radiating bands without any mass-like appearance. So you just have to give the DD of radial scar also. Otherwise, it's good because in our normal practice, we definitely will think that it's a malignancy, and only after biopsy we can find out that it is a radial scar. So child presenting with a motor vehicle accident. This was the first case, I think, where your approach was good. Good, like you are looking at the anterior spinal line, posterior spinal line, spinolaminar line, atlantoaxial distance, and the distance between the spinal spinous process and all. But usually, even if you are following the correct method, this will be missed. Like there is, you can see the lucent line that is separating the atlas with the occipit. So it was Atlanta occipital dissociation that is usually seen in a child. It's an emergency also. You have to refer this to the ortho for further management. So that's it.
Thank you so much, Dr. Sanij. And thank you everyone who participated. We are going to close now. The participant who is left, inshallah, will give her the chance for the next one.
It's already 7. It's already 8 p.m. GMT. Yeah.
Exactly. So thank you again. Thank you, everyone. Thank you for all the volunteers who participated. Thank you, Dr. Sanij.
So actually, next week we have Dr. Vikas Shah doing the hot seat. It's a general radiology session. So we will be inviting the 2 volunteers later. And after that,